Okay, Jenna, if you want to start letting everyone in, please. Oh, hi, everybody. Welcome. I see that you are all in. We are just getting started. I have a slide on my screen here to show y'all if you are getting CME credit. You just need to change your name on your Zoom to your LSU email address. I'm hoping that y'all can see this here. And I will go through so you can get the credit for that. And I'm going to stop sharing. Okay. And everyone's microphones and cameras are turned off for security reasons. And this is being recorded. You'll be able to find it on Facebook Live and also on our lsuhealthfoundation.org email website. And now I'd like to introduce Crystal Oliveira. She is the Chief Development Officer at the LSU Health Foundation.
Hi, everyone. Thank you all for joining us today in our ongoing coronavirus webinar series. We appreciate you making the time to tune in. We are thrilled to welcome back Dr. Susanne Straif-Bourgeois. She is our epidemiologist in the School of Public Health here at LSU. And she was our very first webinar speaker back in April when we first started these webinars. And today she's back with an update on coronavirus and the reopening of Louisiana. So welcome, Susanne.
So I hope everyone can see that. Well, thank you for having me back. It's a pleasure to be here. So what I really want to do today is talk about reopening Louisiana and basically looking backwards, where we are coming from, where we are standing today, and how we move forward. And based on that, how do we look at the data together with the governor and his office to see what kind of data are looked at in order to move from one phase to the other phase. I want to reiterate the importance of wearing masks and social distancing. And then I want to look a little bit towards the future, even so highly unpredictable at that point, about long-term issues, which I think we have to keep in consideration as well. So you have seen that based on my last one, when Dr. Robinson, a colleague of mine, and myself did a prediction model of the spread of COVID-19 throughout New Orleans without any intervention, social distancing, and then the green one is the shelter in place. And then the question is, actually, did shelter in place work? And yes, we believe it did work because the number of cases went down and other metrics as well. So clearly, by trying to reduce exposure to people who are infectious and limit that reproductive number below 1 really helped to prevent that we overwhelm our healthcare capacity, because remember, that was our original issue, that we have to flatten the curve, and the curve would have looked like the blue one if nothing would have been put in place. So I really do believe, and also based on the data, that these shelter at home interventions actually worked. So where are we today? As you all know, is by tomorrow, Friday, June 5th, Louisiana will start to reopen to phase 2. And that's for all parishes except the parish of New Orleans, or Orleans Parish. What that means is that moving from 25 to 50% capacities for both restaurants and other businesses, which were already opened in phase 1, so they can expand. Now in phase 2, also bars, museums, zoos, spas, tattoo parlors, and malls can reopen with up to 50% capacity, but this capacity is really limited to maintain still the 6 feet social distancing, requiring employees to wear masks, encourage customers to wear masks, at least when they enter, and like that. So it's actually a very difficult thing to think about how do you reopen with very, very different kinds of businesses and other things going on. And there's a big commission going on. It's called Resilient Louisiana Commission, which is working to look at all these industries, and the state fire marshal is actually working with the governor's office, and there are a lot of people sitting on that task force. And we as epidemiologists basically look over it and see, is there increased, decreased exposure risk, and so on. So they are currently working on it. Not sure if it's out there yet, but I hope at some point they bring these guidelines out and share that with everyone who really is interested or actually has to see it to reopen their own business. I just want to bring that up again because, again, that's just something we have to keep in mind. Everyone who knows me knows that I really like that map. It comes out of Johns Hopkins, my alumni, but I'm just still astonished if we look by yesterday how many total cases are confirmed in the world, over 6.5 million at that point. And again, US, we still top this number of cases. So these are number of cases, it's not a rate. Brazil is probably at some point catching up with us, and we think other things will come up further. But then we can also drill down based on this website, is that we really can look down on the parish level and on Louisiana. And when you do that, you just click here, what I did for Orleans Parish. You see at that point the rate per 100,000 population, but you also see the number of confirmed cases as of June 3rd, as well as of the number of deaths as well. So it's very unique. You can look over that. I think it's a very nicely visual map, and it gives us a lot of information. So if we then go down to back to the state of Louisiana, there are actually now four gating criteria when we look at the data together with the governor's office and the governor, in order that he actually can decide, do we move from one phase to the other one? Do we have to stay a little bit longer in that phase? Or actually, if it really looks bad, do we have to go back, revert to phase 0, like the stay-at-home order? So these data are 3 different ones, and I go through them a bit. The first one is CLI. That stands for coronavirus-like illnesses. And this is really based on emergency room data. These are syndromic data, so no diagnosis. And I'll show you that in a bit. The second one is our normal epi curve, where we actually look at the number of reported cases. And the last one, which is very important as well, is the number of hospitalizations. And that is really how many patients are still in the hospitals due to COVID as well. So these are the 3 ones which, like twice a week, we are looking together over with the Office of Public Health, because these are all data collected by the Office of Public Health, and then really see in which kind of direction we go. So it's really a combination of looking at all of this data, because all this data tell us something very, very different. So these corona-like illnesses is really based on complaints from persons seeking care at emergency rooms. So that's more or less admission. When you go in, they ask you, what do you have, why you are here? So it's really text field admission 1. So it's really no diagnosis, and there's no testing required. So it basically shows us how many people show up because they show the CLI, which is defined as a fever, shortness of breath, or a cough, and then to see how many of this number of CLI based on all emergency room visits, and therefore the percentage of all emergency room visit is due to corona-like illnesses. And then the Office of Public Health receives all this data from Louisiana emergency rooms, and then they actually analyze it on the time, very timely, because they're coming in all the time, to see if there's an alert, means like there's a higher number than the statistical alert system would tell us, and then they would actually follow up if there's an alert. Now, I cannot show you the data because they are not public yet, but I wanted to show you something very similar, and you probably know how that works, and this is influenza-like illness. Again, very similar. It's also syndromic surveillance, so it's based on symptoms and not on diagnosis. And this is really for the different influenza seasons by CDC week. So it's from 2009 to 2010 up to 17, 18, and they actually already have the last year's data in there as well. But you see, especially when they actually start to more people going to the emergency room because of the syndromes. And you also see here that the 17-18 season was actually a little bit more severe. And what you also see here is, if you look at this green line, the 2009 to 2010, you see actually it peaks much earlier. And you probably all remember that was not the seasonal anymore, that was really H1N1 or the swine flu, which was also considered a pandemic, by the way. So these data are also collected now for corona-like illnesses and looked up if there's an alert. The second one is really our typical epicurve, the number of cases. And normally as an epidemiologist, when we report the number of cases, we also look when they actually had the onset of symptoms. So normally they're recorded based on date of onset of symptoms. And here you see that as well for Louisiana, and it actually fluctuates a little bit. And then you also see that the number of deaths are going down there, which are reported. So when we look at the data, we look at them a bit different. We still look at an epicurve, but the difference is here that we actually look when the clinical specimen was collected and use that date as a proxy, because what the Office of Public Health realizes that they are really inundated, and once in a while, certain commercial labs, it takes them a couple of days to report. So they might get the report a couple of days later, but again, it will be reported based on clinical specimen collection date. Why is it not reported on date of onset and symptoms? Because then you would have to actually interview all of these cases to see when they started to be symptomatic. So that's a good proxy to do based on that. One problem with this epicurve is that it does not differentiate between persons who tested and really shows us the increased testing at nursing homes or due to outbreak investigations, and we look at that in a minute. So when we look at these cases, it basically tells us they had a positive diagnosis of COVID-19. It really doesn't tell us anything at that point of the severity of clinical disease. So some of these people might never show any signs and symptoms, are symptomatic, but they're just part of an outbreak investigation and were tested. It also doesn't show how many of them have only mild signs and symptoms. It doesn't show us how many of these actually have to be hospitalized or actually severely ill and die because of COVID-19. So it just shows the number of cases over time based on clinical specimen collection date. So that's where the third one comes into place, the hospitalization. So here it's actually, we are looking at the number of COVID-19 cases who are still in the hospitals. So it's not number of new admissions due to COVID-19, but how many people are still, based on that day, hospitalized because of COVID-19. And as you can imagine, how the number of hospital days, how they spend in the hospital, is really associated with risk factors. As we know, increasing age, but also hypertension, diabetes, cardiovascular disease, obesity, kidney disease, and other ones as well. So this is really not showing us again, how many people stay how long in the hospital, but it's a really important metric, actually, I think a very important one, because it really shows us, are these numbers increasing, and are we getting close again that we are over healthcare capacity? Do we have enough beds in ICU? Do we have enough vents, ventilators, and other things like that? So that's the third metric. And then the newest one, which I really like, is just on Tuesday, it was the first time we looked at these data, is the test positivity. So as you can imagine, that when you do more and more testing, and you will see that more and more testing has to be done to keep COVID-19 under control, is to look at the number of positive tests divided by the number of tests per day, to keep it very simple. So you look how many of the ones who were tested show up to be positive. So this represents the percentage of test positivity and is not biased, such as the Epi curve, because of increasing testing capacity. So what I do say here is, if we see more cases going up over time, that might not tell us necessarily that we have, again, an increase of number in cases, but it could be just due because we test so many more people. So if we test more people, we assume that more people will be tested positive. So it's less likely to be biased towards if we just would be perfect. So all these metrics have to be very careful looked at, because there are still some other missing metrics. Again, I think the disease severity of all reported cases would be very interesting, but you can imagine that the Office of Public Health, the epidemiologist, the surveillance personnel, they just are totally inundated, so they really cannot do that. They cannot follow up and see how they are categorized. But I think that would be very interesting. And they told me at some point they probably will have to look at that. The other problem is persons who are still in the hospital. This metric is also kind of different when we looked at it, because we realized that some skilled nursing facilities, which might be part of the hospital, if they transfer their residents or patients into the hospital, they also increase by that the number of hospitalization, and that might actually show us not a very correct picture because they were already in a skilled nursing facility. So these are all the things when we look at the data. And when we look at the data, we look for the state of Louisiana, and then we look for all the 9 administrative regions which the Office of Public Health oversees. So all of these go together, and based on that, the guidance comes up to think about, can we move to the next phase? So really, I want to focus here on phase 2, because again, by tomorrow, except Orleans Parish, we will reopen to phase 2, which is considered a medium risk. And here you really want to see that all phase 1 gates, these criteria, are maintained and successfully completed. So basically 21 days. Remember when we started to go in phase 1, that was around May 15th. Then you need really 21 days of data and really want to see that these number of percentages are decreasing. You look at fluctuation, and there are certain statistical methods to actually look at that. And if that's really tells you that, then you really can move forward as the governor decided we are ready to move into phase 2. However, if these numbers are going up quite a bit, then we might actually have at some point to revert to phase 0 again, if there's especially in certain regions or in Louisiana, rapid increase of the number of cases, or another big concern that medical service become very unstable because more and more people have to be hospitalized. And again, we get to that limit of healthcare capacity. So this, even being in phase 2, is really that we cannot ignore the importance of masks. And if you go at the LDH, the Louisiana Department of Health website, you see what the importance of mask is, because you're really protecting other ones, especially if you don't have any signs and symptoms, but you go and do your food groceries out there. And again, by wearing that, you protect other ones from infecting them. So you, again, by this doing that, limit the spread of the disease. And I'm not sure, you probably were out doing some groceries and other things like that. I'm a little bit concerned about a very low compliance of people actually doing that. But it's important, again, as a part to really limit the spread. The other one is really social distancing, as you see on these guidelines from this task force about resilient Louisiana. So this virus, SARS coronavirus 2, is mainly transmitted through droplets which are greater than 5 microns. And these actually fall on the ground within 6 feet. Therefore, our social distancing, or actually physical distance, between 6 feet. Because even if someone expels these droplets, they should fall on the ground within the 6 feet. So you seem to be safe if you are more than 6 feet away. However, there's a but, there's always a however in there. We know that certain activities like singing, speaking loudly, or playing a musical instrument with your mouth and therefore have a higher lung capacity, these droplets can be aerosolized. So aerosolized mean they actually will be smaller. And if they're smaller, you can imagine what they can do. Then they can actually stay longer in the air. And I will show you an example about that, about an outbreak which happened in Washington State. So other than that, there is also evidence of that the virus can be transmitted via environmental transmission, fomite transmission. This virus can survive in the environment depending on the surface. So persons can become infected when touching high contact surfaces, door handles, elevator buttons, toilet handles, and then touching their face. So that brings us to the last one, wearing a mask, social distancing, and wash your hands. All of these have to really kept in order to not increase the number of cases. Also here again, when I said mainly, that's the main route of transmission. So we really cannot put a percentage in there. We know things are likely, but probably not as likely as the main transmission of these droplets. Another important is before the governor actually decided to open to phase 1 to start to do contact tracing. So contact tracing is really that you would like to identify people who are confirmed with COVID-19 and then follow up who was actually in close contact with them, and then make sure that these people are aware of it and actually quarantine themselves because they were potentially exposed to COVID-19 or SARS coronavirus 2, and then you will have to follow up on them as well. So the Office of Public Health started that on May 15th as well, and you just see there's a couple of logos on there, is that all COVID cases, as soon as they're reported, will be contacted by these contact tracers within 24 hours when the report that they were tested positive comes in. Then they talk to the case, tell him or her that they should self-isolate because they're a case, so isolation until fever or other signs and symptoms disappear, as long so that they are not going back out while they're still infectious. The contact tracers will then call and interview that case, that actually what I just said, to know who was in close contact during the infectious period. So the infectious period is 2 days before onset of signs and symptoms. And therefore they have to ask that case, when did they start to have signs and symptoms, until that case actually self-isolated him or herself and is no longer symptomatic. Then these contact tracers will call all the contacts to let them know that they were exposed to someone who was diagnosed with COVID-19, and they should quarantine for 14 days. And if you remember, the 14 days comes from the maximum days of the incubation period. So if they don't show any signs and symptoms within 14 days, then they are not considered to be a case. However, if they start to become symptomatic, they have to be tested right away. So these contacts are daily followed up for 14 days. So that's a lot of work. And then if they have any questions, they again will be referred to other resources, but also most importantly, make sure that they actually find a testing site or will be referred where they can get tested right away. They also get other referrals, like to food pantries, like someone who was a contact and has to quarantine, but they really have no one to bring them food. So they get also resources from Second Harvest, other food banks that they still get food, medication refills and other things, mental health support, and everything is also available for them. So you just, well, you cannot go out, you have to quarantine for 14 days, but you really try to have enough resources around it that they can successfully quarantine. It's also important to know, since this is public health, that privacy and confidentiality is ensured. And I know a lot of people have concerns about it, but the name of the case never will be released. So it will be confidential. And so that's very important to know as well. Besides contact tracing, the other one is really outbreak investigation. And I mentioned that earlier on, that you really have to focus at that point at congregate settings. Congregate settings are where people are very closely to each other indoors, and there's potentially high exposure going on, especially if one is infectious, and easily at that point the virus can spread through these congregate settings. And you also know the first nursing homes in Louisiana was the Lambeth House already in March 20. But as you know, and the Office of Public Health released that, there were many, many nursing homes who were impacted, had outbreaks, and because of that highly vulnerable population, unfortunately also a lot of people had died of that. Currently, the Office of Public Health actually is testing each nursing homes repeatedly just to make sure that this is not going to happen again. But then we also have seen outbreaks. You probably heard about the crawfish farms, which happened mid of May, where basically, and if you see that on the top, actually there were 3 crawfish farms and about 100 people, 100 workers of them tested positive. Again, as I said earlier on, even so they're tested positive and are considered a case, none of them had to be hospitalized. Most of them did not have any signs and symptoms, but because it was an outbreak investigation, everyone, of course, needed to be tested. And you have seen that in other parts in our country as well, the meat plants, Tyson, and other one, and I just put you something down from the Des Moines Register from June 2nd, how many workers in these plants, in these meat plants, actually tested positive for COVID-19. So again, congregate settings, standing very closely to each other, working on the same line, perfect environment for this respiratory disease to spread. The other one are churches, and that's very kind of interesting because they have actually church outbreaks, and the most famous one, because it was also published by CDC, is the one in Washington State that was actually a choir practice. And what they realized that one person, that was the index case, that's the little red person there, were actually able to infect 87% of the group who also attended the choir practice. And therefore, again, the concern is that while singing or practicing singing or choir, again, these droplets might aerosolize and therefore more likely to actually infect many more people at the same time. Correctional facilities is clearly a concern as well. And also the Office of Public Health is currently doing increased testing in correctional facilities, not only inmates, but as you can imagine, staff and other people as well. So more and more testing is done to really make sure that outbreak investigations are done and to prevent the spread back into the community, and then you might have a problem again. So when I talk about long-term issues, is again, we still don't have a good antibody tests out there. There are a lot of people who are advertising to get tested, but I really question that at that point, because even so, if the antibody test is a good one, meaning high sensitivity and specificity, we have some other issues with that. And really the most important question, even if it's a good antibody test, it really does not tell us if we are immune, because that's what we all would like to know. We are antibody positive, that means we are immune for whatever time we know. So just seeing antibodies does not mean that that person will be immune. There are a couple of steps between that. You have to find the right antibodies. At that point, we really don't know how long the immunity will last. We don't have enough data on that. But what people actually looked at is at SARS, which happened in 2002, 2003, that it seems like people have a short-term immunity, a little bit like our seasonal influenza, most likely for 2 to 3 years. What that also tells us about the epidemiology, that we will continue to see peaks of COVID-19 coming up. The biggest question now is, because we are already at least in the US about 4 or 5 months into that, mutations. So this is a virus. Viruses have the tendencies that they like to mutate, but the question is, if it mutates, how will they impact the epidemiology of this virus? Will it become weaker? Will it become more infectious? Will it become more deadly, and other things like that? So we really don't know that at that point. So I just found the other day in a British magazine or newspaper where actually Italian doctors say that the coronavirus is weaker than it was during the height of the pandemic, because as you can imagine, or if you probably have heard about that, this little town in North Italy, Bergamo, had one of the highest death rate. And now they think that actually the COVID virus or SARS coronavirus 2 changed and became weaker, and therefore the death rate actually went down. To be honest, I'm still a little bit skeptical about that. And I'm not sure if you heard about Sweden. Sweden had a totally different approach to this pandemic. Basically was relying that people will get enough immunity and the herd immunity, and they really did not do any mask, shut school down, stay at home, and other things like that. They really counted that if people are sick, they stay home, but really did not shut anything down. And they just today actually said that their approach totally failed. And what we know now is that Sweden actually has one of the highest death rates, even higher than actually Italy or this little town in North Italy had. So I'm not sure if it's the same virus, is it a more deadly one? So again, I think in the future we'll learn much more about these mutations. So we also know that it will most likely to act seasonal, like SARS did, but Yes, we know that seasonal influenza normally starts from October 1st to March 31st. And we all expect there will be a second wave in the fall. And it will coincide with seasonal influenza. So that might be a problem because they're both respiratory one, kind of difficult originally based on signs and symptoms to differentiate and other ones. I was asked at some point if I think the second wave will be bigger or smaller, and I have no idea what they will see, but the person who asked me, if you read the 1980 pandemic flu, there are so many books out there, all of them are really interesting, but you might remember that the second wave for the 1918 pandemic flu was actually bigger than the first wave. So you hear about vaccine is in development. Some people already target that it can be already deployed in the fall, maybe in the spring. But we also see on the other side, there's already a big movement from anti-vaxxers, and there are actually different polls out there from different population in the US, where people say about from 50 to 60% say they will take the vaccine for or against COVID-19. So clearly, even if that vaccine is 100% effective, that really never would bring us to this herd immunity of at least 60%. So the vaccine might be not the solution or the end of the tunnel at that point. I personally think it will stay here, will stay with us, and we will see different waves of COVID-19 and of SARS coronavirus 2 virus. So any questions? I hope I didn't talk too much or spend too much on the presentation.
No, that was great. Thank you so much. We do have some questions, so I'm going to go ahead and get those started. Ooh, lost my chat. All right. We have a viewer asking, what if someone tests positive, has no signs and symptoms? Will they be asked to self-isolate or just quarantine? And what's the difference?
Okay, so yes, if someone tests positive, like we have seen in this people who worked at this crawfish farm, we still assume people who do not have any signs and symptoms can still spread the virus. And therefore we ask people to wear a mask, even so they feel fine if they go in public spaces. So yes, they should be also isolate. And here it gets a little bit more difficult because they don't have signs and symptoms. So they normally say about for 10 days to be sure that they are not infectious anymore. The difference between isolation is isolation if someone who is diagnosed with the disease and will be isolated from other ones not to infect them. Quarantine is if someone was exposed but does not have the disease yet, but you want to follow up on them to see if they develop the disease within the incubation period, and then follow up on them and get them tested. So isolation are patients who have the disease, quarantine are the people who are exposed to that person.
Okay, I didn't realize there was a difference. I never thought about it. Someone's asking, what about the recommendation to stay 10 feet apart rather than 6 feet apart?
Yes, so what we actually see, again, this goes back to aerosolization, the 10 feet is clearly safer, especially, you know, if someone sings or yells or speaks loudly and other things like that. But when I have looked at the guidelines of this task force, at that point, everyone talks about 6 feet distance, because that's the main route of transmission, at least what we assume at that point or what we know at that point. So 6 feet is, yeah, makes sense. But of course, 10 feet is better if you want to do that.
Mm-hmm. And you really believe in wearing the masks? You think that that is?
Mask, again, as we just talked about, is very important because we know based on data coming out of other countries that everyone who is tested, that over 33% of these people do not show any signs and symptoms, and they're still able to transmit the virus. We also have to think about these people who do not have signs and symptoms. They're pre-symptomatic. Remember, we talked about people who will be a case. We have to go back when they start to have onset on symptoms, signs and symptoms, and then have to go another 2 days back because we assume that they're already infectious. So yes, masks, very important.
Okay. We do have some more questions. What can you say about children who have tested positive for Kawasaki disease who have been previously tested positive for COVID?
I cannot say too much about it. I know there are a couple of studies going on there, but to be honest, I'm not up to date on the literature about that.
Mm-hmm. And just so everyone knows, we actually had a pediatric cardiologist on last Friday, Dr. Bradford from Children's, and that webinar can be seen on our website, the recording. So y'all can please go watch that if you have questions. She answered a lot of questions. All right. Can you clarify again the difference between self-isolation and quarantine? It sounds like it depends on whether you have it versus just having been exposed.
So isolation, and we do that in the hospitals all the time. Let's think about someone who is infected with tuberculosis, a very infectious disease, airborne transmission, so much more infectious than COVID-19, but we have to put them in isolation rooms. So we consider them, they're tested positive, they're infectious, and we have to isolate them either on the hospital ward or somewhere else to not transmit the disease. When I talk about self-isolation is if you have COVID-19, you are confirmed to have COVID-19, but you really don't feel that bad. You might have a fever, but again, you don't need to be hospitalized. So then you really ask these people to self-isolate, to stay at home. Don't go out to do your grocery shopping and other things. Really isolate yourself in order to prevent the spread of the disease. And quarantine, again, are people who do not have the disease yet, but are at higher risk because they were exposed to someone who was a case or is a case.
And then, so what is the difference in behavior they are asking? So between quarantining and self-isolating, is there a difference?
So yeah, that's a good question. So self-isolating, again, these people, if they're confirmed to be a case, they will be called up and are asked to really isolate, stay at home, not to mingle with their household members and other things until more or less the symptoms disappear. And they don't show any signs and symptoms anymore, because then we consider them not to be infectious anymore. So for people who do not have any signs and symptoms, but were exposed to someone, they also should stay at home, quarantine, also do not go out, and they will be actually monitored daily by these contact tracers. They call them and ask them every day, do you still feel okay? Did you start to have fever, other symptoms? And if they say any of them, yes, I started to be really tired, or my muscle pain, or I really don't know what's going on, then this contact tracer will make sure that they find a place to be tested.
Okay, that makes sense. And what are you thinking about as an epidemiologist? What are your concerns about people being together, like with the protests and everything? Is that concerning to you, the crowds?
Yes. So it's clearly a problem, but you see a lot of them have masks on, which I'm not sure was the original intent that protesters have masks on, but some of them really have masks on in order to prevent the other one. I think the only good one, because they are very close by, is again that they are outdoors. So again, in these days when we have a warm weather, high humidity, we assume that the virus is less viable in outdoor settings, but again, it still can spread. But again, it would be nice if they could keep 6 feet distance and wearing a mask and washing their hands and of course, you know, drinking water because they walk a lot and other things like that.
Okay. Well, that's good news though. They are outside and the weather is warm.
Exactly. And they walk and I mean, yeah. And I think it's a good thing that they do that.
Yeah. And if there's any more questions, y'all, please post them to the chat. Something I wanted to ask is, right now, as a healthcare expert, what is giving you the most hope for this pandemic and what you're seeing?
I think the numbers are going down. I think as everyone else, when we start tomorrow to open phase 2 and go a little bit back to normal, I think that gives everyone hope, gives our children hope, gives everyone hope that there is some kind of going back to normal. The economy can go up, so it's getting better and better by the day. My concern is really that people really do not comply wearing masks. Again, the concern is congregate settings that then the virus might spread in the community and then you might have the problem again. I'm really concerned about the fall because I really think seasonality has impact on that. I really don't know how much or no one does. So I think the summer should be okay for us. My concern is in the fall. We want to start to have our students back on campus. The kids want to go back to school. So again, we go more and more into congregate settings, which might actually overlap with an increase of COVID-19 cases anyhow. So that's why I'm talking about the second wave.
Mm-hmm. Somebody's asking, does wind play a factor in expediting the spread of COVID particles in comparison to dry, humid weather?
Can you repeat that? I have someone cutting the grass outside.
No, that happens. Does wind play a factor in expediting the spread of COVID particles in comparison to dry or humid weather?
Yeah, so that's actually a very good question. Yeah, wind actually would play a role, and you probably have seen, it just came out this morning, that they really disencourage police to do the gas and other things like that in this crowded population, because then you might actually circulate the virus if there's any around and might increase the risk of getting exposed and other things like that. What we know from SARS as well as seasonal influenza is, and you probably have seen that old pictures of 1918, that in the summertime, they put all these people who were in the hospital outdoors. Again, the virus does not like sunlight, UV light, and does not like high humidity.
Okay. And someone's asking, what practical steps can daycares take to protect young children from COVID? Yeah.
That's a very lengthy answer for that, but there's actually currently also guidelines prepared from the governor's office about recommendation for daycares, elementary school and other things, summer camps. So they are working on that. And if they're not out there yet, I'm pretty sure they will be made available soon.
Mm-hmm. Okay, I think that's all of our questions. Thank you so much for your time and all the information. It was
no problem at all.
Interesting and very helpful. Just to let everyone know, like I said, the recording will be available on our website at lsuhealthfoundation.org/coronavirus. Our next webinar will be next Thursday with some LSU Health pathologists. And you can sign up with that. I've posted the URL on our chat. You can sign up for that webinar next Thursday at 11. And I think that's everything. Everyone, please take care. Thank you so much for being with us today.